Thank you to our audience for spending this afternoon with us, learning about your kidneys and your heart. Let's begin by talking about your amazing kidneys. We all have a pair of bean-shaped organs, our kidneys, which are located at the lower back of our body, and they're roughly the size of our fist. They work to remove toxins from the body, as well as to regulate salt and water content in the body. Our kidneys also produce hormones that are necessary for good bone health and for red blood cell production. In a normal situation, how the kidney works is that blood with waste products is brought to the kidney by the renal artery. It is washed through the kidneys through these tubules, and then the renal vein brings the clean blood back to the rest of the body, while the ureter carries urine with all the waste products to the bladder to be excreted from the body. In chronic kidney disease, there are some abnormalities of kidney structure or function that are present for at least 3 months, and either the glomerular filtration rate is less than 60 when measured, or there are some other markers of kidney damage, such as having protein in the urine, also called albuminuria. How we derive the glomerular filtration rate is through a blood test where we check for the serum creatinine. We then plug the serum creatinine into a very complicated equation to derive the glomerular filtration rate. In this table, we see how the Kidney Disease Improving Global Outcomes, or KDIGO group, has classified chronic kidney disease. An increasing stage of glomerular filtration here actually signifies worsening or increasing severity of kidney function. And if a patient is at stage 3 and above, that is the time when they should be referred to a nephrologist or a kidney specialist, because it is around this time that complications associated with poor kidney function arises, and we have to look for these complications and treat them accordingly. This first graph on the left also tells us that when the eGFR is less than 60, which is stage 3 and above, the risk of death actually increases. This graph on the right tells us that when the amount of protein or albumin in the urine increases to beyond 5, the risk of death also increases. So for a patient who has albuminuria and the reading is more than 3 to 5, this patient should also be referred to see a kidney specialist. Let us look at the magnitude of kidney disease. Now, chronic kidney disease is a silent killer and can affect about 10% of the population. It can affect people of all ages and races, and about half of people aged 75 and above will have some degree of CKD. 1 in 5 men and 1 in 4 women between the ages of 65 and 74 also have CKD. The most common causes of chronic kidney disease are high blood pressure and diabetes. Now, unfortunately, early chronic kidney disease often has no signs or symptoms, and a person can lose up to 90% of their kidney function before they actually experience anything different from their daily life. And that is because the body has over time acclimatized to having more toxins in the body, and so the patient actually doesn't feel very different till they have lost a significant proportion of their kidney function. The risk for cardiovascular disease also increases when the kidneys do not function so well. In this graph on the right, we see an independent graded association between reduced eGFR, that means a worsening kidney function here along the x-axis, associated with an independent increased risk for death and cardiovascular events such as heart failure, ischemic stroke, or peripheral artery disease. This is a slide showing us some of the risk factors for cardiovascular disease. And of note, chronic kidney disease stage 3 and above, with or without albuminuria, is also a significant risk factor for cardiovascular disease. In order to maintain healthy kidneys, it is important that we avoid the causes of acute kidney injury, because any episode of acute kidney injury would increase the risk of new or progressive chronic kidney disease. It also increases the risk of end-stage kidney disease and death. A higher stage of acute kidney injury, for example, someone who just has a slightly raised creatinine versus someone who actually required dialysis, even if temporarily, that would put the individual who required dialysis at a higher risk of future kidney disease and death. We also need to control risk factors that worsen chronic kidney disease. And so we will look at some of these factors in the next few slides. Some causes of acute kidney injury include dehydration. In a warm tropical climate like Singapore, and also in Bangladesh, where you can be quite humid too, a person with normal kidney function should drink at least 2 liters or 8 glasses of water daily. And if you're exercising or going out in the sun a lot, do increase your fluid intake. Please try not to self-medicate or to share medications with a family member, especially over-the-counter painkillers, as some of these painkillers actually are harmful to the kidneys if taken regularly over the long term. Now, if you are already on some prescription medications, again, it is more important here not to self-medicate, because there could be some drug interactions that you may not be aware of, but that can happen giving rise to toxic levels of certain drugs that could harm the kidneys and/or the liver. Some other causes of acute kidney injury include contrast-induced nephropathy, especially in patients with underlying chronic kidney disease. This happens when intravenous contrast is injected for purposes of a CT scan that is sometimes ordered for patients when the doctors are not aware that they have underlying kidney disease. Infections that affect the kidneys, the bladder, or even in the blood can also cause the kidney function to go off. Kidney stone disease can cause obstruction to the flow of urine and affect kidney function. There are also some pregnancy-associated kidney diseases that we may have to look out for in patients at high risk. And crush injuries can also cause release of certain pigments from the muscle to get lodged in the kidney tubules and affect kidney function adversely. Some causes of chronic kidney disease include high blood pressure and diabetes, as we mentioned earlier. Other causes are like glomerulonephritis, which is an inflammation of the kidney from various causes, obesity, where the kidneys are just overstressed and overworked, or polycystic kidney disease, which tends to run in families. Patients who have recurrent urinary tract infections can also have ascending infections, so that the bacteria actually gets into the kidney and causes scarring if there are recurrent infections. Kidney stones, as we mentioned earlier, they can cause obstruction to the flow of urine and adversely affect kidney function if the obstruction is not cleared in a timely fashion. Knowing all that, we need to identify and control risk factors for chronic kidney disease. Let's begin by looking at diabetes. For diabetics, it is important to keep your HbA1c between 6.5 to 7 if you're 75 years and below. And if you're aged above 75, it is important to keep the HbA1c less than or equal to 7.5%. The HbA1c is glycated hemoglobin and gives an average reading of the blood sugar for the past 3 months. So if the average reading is anything more than 7 in a younger patient or more than 7.5 in an older patient, it tells us that the diabetes has not been very well controlled, and that in the long run can give rise to other complications like kidney disease. It is also important to control blood pressure. For patients without albumin or protein in the urine, their blood pressure can be kept to less than or equal to 140/90. For patients who have protein in the urine, the blood pressure should not be more than 130/80. It is also important to adhere to a healthy diet. A low salt diet is very important for good blood pressure control. So these are some of the sauces we commonly use for Asian cooking, And reducing the use of these sources in cooking will help to reduce the amount of salt in the diet and help in overall blood pressure control. A diet rich in whole grains, fruits, and vegetables is also important for good cardiovascular and therefore good kidney health. For patients who have advanced kidney disease, we advise them to lower their protein intake to about 0.8 grams per kilogram body weight per day. The reason is because the metabolic waste product of kidneys is removed by the kidney, of protein is removed by the kidneys. The acid generated, especially from meat proteins, has to be removed by the kidneys, and when the kidneys don't function so well, having a high protein intake increases the net acid level in the body and stresses the kidneys. While we mentioned earlier that someone with normal kidney function should drink at least 8 glasses of fluid a day, for someone with advanced kidney disease, where the kidneys cannot remove so much fluid anymore, it is important to restrict fluid intake so that the water doesn't go to the legs to cause leg swelling or into the lungs to cause breathlessness. Adhering to a healthy lifestyle is important for both cardiovascular and good kidney health. There is no such thing as healthy smoking, so everyone should just try very hard to stop smoking. Alcohol consumption should also be limited. Physical activity compatible with the cardiovascular health and tolerance should be undertaken for at least 30 minutes 5 times per week. And that is to aim for a healthy body weight with a body mass index of between 20 to 25. For a patient who comes to us with chronic kidney disease, it is important to look for and identify complications. We mentioned earlier that the acid level could be high, and that's found out through a blood test where we look for the bicarbonate. If it's less than 22, it means that the acid level is quite high, and we can give some medications to deal with this. As mentioned earlier, the kidneys also secrete a hormone necessary for good bone health. When the kidneys don't function so well, the serum calcium phosphate and parathyroid hormone levels can sometimes go a bit off, and we'll have to look for, identify, and treat the complications. Anemia, defined as a hemoglobin of less than 12 in women and less than 13 in men, can also happen in patients who have chronic kidney disease. And for such patients, we can give them some hematinics like iron and vitamin B supplements, as well as some recombinant erythropoietin injections to help improve their blood count and give them more energy. As chronic kidney disease is an immunocompromising condition, it is important that all patients with advanced chronic kidney disease get timely vaccinations. These include influenza vaccine, the pneumococcal, influenza should be annually, the pneumococcal vaccine, which is the 2-dose vaccine, a hepatitis B vaccine, if you're not immune to hepatitis B, and for the COVID-19 vaccine, for a pre-transplant patient who is not on immunosuppressants, they can go ahead to receive the COVID-19 vaccine. But for a post-transplant patient, or for some patients with chronic kidney disease who are on immunosuppressants, they have to make sure that they receive only the killed or alive attenuated vaccine. We know that the normal kidney functions to remove waste products, regulate salt and fluid balance, and produce hormones necessary for regulation of blood pressure, blood production, and good bone health. So in kidney failure, what happens is that a patient may just feel more nauseous or have some itch in the skin because of accumulation of waste products in the blood. They can also feel more tired than usual because of low blood count, or they can have leg swelling, especially towards the end of the day, because the kidneys are not working to remove that excess fluid from the body. They can have anemia, as we mentioned earlier, or the blood pressure can be very high due to the lack of hormones that regulate blood pressure, or because of the overall accumulation of excess water in the body. In the long run, if we don't identify and treat these complications, bone health also suffers, and patients with kidney failure can get fractures a lot more easily compared to someone in the general population. As we mentioned earlier, chronic kidney disease often doesn't come with a lot of signs and symptoms. Therefore, to identify kidney disease early, regular health screening is very important. And this includes regular blood pressure checks. In this day and age, we can easily buy a blood pressure monitor, keep it at home, and just check our blood pressure once a day. A urine dipstick can be bought from a pharmacy, and after collecting a midstream urine collection, you can actually put a dipstick in to look for protein, to look for blood. You can also look out for chalky or frothy urine. So on the left here is a normal urine sample. This is chalky urine and this is frothy urine. Chalky urine suggests the presence of blood in the urine, while frothy urine suggests the presence of protein in the urine. If you have any of these signs, it is important to see your doctor for a thorough health check to ensure that you do not have underlying kidney disease. For patients with kidney disease, and for all of us, for good general health, it is important to adhere to a healthy diet and lifestyle, avoid taking over-the-counter painkiller medications, and please take all medications as prescribed by your doctor and keep your follow-up appointments with your doctor. Do get your kidney function checked regularly if you have diabetes or high blood pressure, or if your body mass index is above 25, or if you have a strong family history of kidney disease. To support a loved one who has chronic kidney disease, it is important to know that the kidney disease usually doesn't tend to occur alone, but is a result of other medical problems. And therefore, we want to encourage and be a part of their healthy lifestyle. We eat the same healthy food, we exercise along with them to show them that we are supporting them along this journey. If possible, we try to accompany them to their medical appointments to offer emotional support and empathy. Chronic kidney disease can be treated, and its progression can be slowed down with good control of risk factors. You can live long and well with chronic kidney disease because currently there are many treatment options which offer hope to CKD patients. And so with this, I thank you, and I'll hand it back to Farzana.
Yeah. So today I'd like to thank everyone for joining us this afternoon for this wonderful opportunity to share about heart disease as well as kidney disease. So in the next 20 minutes, I would just like to talk about some of the common myths about heart disease. So as Farzana has mentioned, I'm an interventional cardiologist, and I'm actually part of a group of dedicated cardiologists with varying specialty, and we come together and call ourselves the Asian Heart and Vascular Center, and we operate in the major Parkway hospitals in Singapore. Now, perhaps I can just start with a simple illustration. This is a 54-year-old gentleman who's physically fit. He eats healthily and he doesn't smoke. Yet, when he came for health screening, he was found that his cholesterol was high. And lo and behold, he does have coronary arteriosclerosis with a coronary calcium score of 300 and above, all of which without him knowing that he has underlying heart disease. Or perhaps another example is a 42-year-old, actually distant relative of mine. Now, she was previously well with normal blood pressure, normal cholesterol. She doesn't smoke, rarely drinks alcohol, but she just had some recurrent gastric discomfort, which appears to be quite common for a 42-year-old lady. But when we did a stress test, it was very abnormal, and after an angiogram was done, she was found to have very severe 90% blockages in 2 of her coronary arteries. Unfortunately, we detected this all before something worse may happen. So, about hearts. Why are our hearts important? Well, you know that our hearts supply oxygen and nutrients to the rest of our body. And there are very many different kinds of heart disease. And as shown here, many things can go wrong. We can get heart failure, we can have coronary artery disease, some unfortunate patients may suffer heart attacks, or you can have cardiac arrhythmias or irregular heart rhythm, and some patients may get valvular heart disease. And we all know that heart disease is a very serious problem. In many Southeast Asian countries, cardiovascular disease is the second commonest cause of hospitalization and death, next only second to cancer. And coronary artery disease, in other words, the blocked arteries alone, they will account for 20% of all hospitalization and mortality cases. As more people around the world, hopefully, adopt a heart-healthy lifestyle and take medication to lower their heart attack risk, deaths from coronary artery disease have reduced globally. Yet, myths about heart disease and its prevention persist, and these misconceptions about heart disease can be very dangerous. So what I would like to talk about is some of the common myths about heart disease. First of all, very often I hear people telling me, well, you only get heart disease if it runs in the family. Yet others will say, no one in my family had heart disease. Why? Why did I have a heart attack? Another patient told me, my grandfather had a heart attack. Well, am I at risk of heart disease as well? Well, indeed, genetics sometimes play a role in developing coronary artery disease. However, 90% of heart disease actually results from harmful lifestyle choices, including poor diet, smoking, and little or no exercise. Of course, heart disease can run in the family because family members share genes, but they also share behaviors, lifestyles, and environments that can influence their health. Genetics can also influence high blood pressure, heart disease, and other related conditions. The Global Interheart Study actually identified 9 risk factors that account for more than 90% of heart attacks. And these risk factors are, as you can see here, high cholesterol or lipids, smoking, diabetes, obesity, hypertension, psychosocial stresses, lack of fruits and vegetables, lack of exercise, and alcohol intake. And the top right panels and all these risk factors there, like high blood pressure, smoking, diabetes, obesity, and high cholesterol actually account for more than 90% of cases. And then you can see these are risk factors that we can modify through lifestyle changes. A second misconception is, patients will say, I'm young. Perhaps some of the audience will say, I'm only 30 years old. I don't need to worry about heart disease. That's something for the old people. Well, of course, it's true that heart disease is more common as we grow older. But how we treat our hearts now, when you're young, will have long-term consequences. If you smoke, you're overweight, or have diabetes, this can increase your risk for heart disease no matter what age you are. Because arteriosclerosis actually starts from a very young age. This is a picture of a blood vessel. On the left panel is when the blood vessels is nice and clean, but by the time we are in our teenagers, 20s, 30s, or 40s, we start to develop small cholesterol plaques or fatty yellow streaks in the blood vessels. And over time, this will gradually accumulate and become a bigger plaque. And one unfortunate day, the plaque may rupture and cause a heart attack. And this can happen 20, 30 years after the initiation of these plaque deposits. So even if we look at the hearts of children or even adolescents and young people, these plaques may already be present in the heart. And young, middle-aged people can also get heart attacks. Unfortunately, today, we are seeing more men and women in their 30s and 40s with heart attacks. And in addition to coronary artery disease, younger people may be afflicted with other kinds of heart problems, such as arrhythmias or irregular heart rhythm, inherited heart conditions, such as thickened heart muscles, what we call hypertrophic cardiomyopathy, They may get heart failure, some forms of congenital heart disease, or even have strokes. Next, it's also a common myth that heart disease is a man's disease, because most people think that patients with heart attacks are all middle-aged men. But the truth is, heart disease is actually a leading cause of death in women worldwide. 1 in 3 women sadly die from heart disease, and this is more than breast cancer, womb or uterine cancer put together. And heart disease in women are often missed. Why? Because the symptoms between men and women are very different. During or even prior to a heart attack, 70% of women may experience unusual tiredness or fatigue or shortness of breath. And actually, half of women who had heart attacks do not even experience chest pain or chest tightness. They are more likely to experience just a vague nausea, vomiting sensation, dizziness, tiredness, jaw, or perhaps back pain. And they may not have the classical central crushing chest pain even during a heart attack. On average, women, the same men and women with the same risk factors, for women, they may still get heart disease, but probably 10 years later than men, mainly because they are protected by the female hormones, estrogen, until menopause. But thereafter, their risk of heart disease significantly increase. So, screening for heart disease is just as important for women as for men, and should be as routine as mammograms and pap smears. So for the ladies in the audience, do recognize and manage your risk factors. Pay particular attention to your weight and body mass index, your waist circumference, blood pressure, cholesterol, and your fasting blood glucose. Now, a lot of people think that small heart attacks, well, are small heart problems. So I had patients who told me, well, I had a minor heart attack. It's not that serious. Well, heart attacks are due to what we call acute coronary syndromes. And we differentiate them to the amount of damage, heart muscle damage, that is caused. So for those with small heart muscle damage, they may be what we call unstable angina or non-ST elevation myocardial infarction. Whereas for those with a lot of muscle damage, well, we call it acute myocardial infarction. But we want to look at the cause, underlying cause. This is the picture of the blood vessel. In this left panel, this is the blood vessel on the right coronary artery, and you can see a tight blockage where the arrow is pointing at the beginning of artery. Because the blood vessel is not completely blocked, it's what we call a unstable angina, non-ST elevation MI, or a small heart attack. On the right panel, basically, the blockage is a little bit more severe, almost 100%, and this is a big heart attack. So is there a difference between the two? Well, very little difference. Both are equally dangerous and life-threatening and can potentially lead to death. Both patients are at high risk of abnormal heart rhythms, recurrent heart attacks, or stroke. So even though the left panel may be so-called a small heart attack, the risk of demise or death is just as high. What about stable patients? Well, some patients say, well, it's not so urgent to treat stable heart disease. But do realize, any delay in treating underlying heart disease can lead to severe consequences. If you have stable coronary heart disease that is left untreated, this may lead to heart attack, heart failure, or even death. If you have heart failure, patients may get prolonged, pronounced fatigue, and that can lead to permanent organ damage, cardiac arrest. And those with irregular heart rhythms, such as atrial fibrillation, may have recurrent fainting spells that can lead to injury or even stroke. And patients with valvular heart disease are also at risk of heart failure and stroke. So if we don't deal with these problems while they are stable, they subsequently can lead to multi-organ damage, kidney failure, stroke, and even death. And if these patients are present to hospital with other problems like chest infection, pneumonia, stroke, if they have untreated heart disease, this can significantly reduce their risk of survival. Next, how do we treat heart disease? Coming to treatment, the two common treatments will be angioplasty or coronary artery bypass grafting surgery. Well, some patients think that if they go for either stenting or what we call angioplasty or bypass surgery, their hearts are completely fixed permanently. Well, let's talk about these treatments. For bypass, as you can see in this picture here, the surgeon just takes a blood vessel and put it beyond the blocked artery to supply the heart muscle. And as for angioplasty, as you can see in this left panel below, there's a blocked artery with plaque deposits. We will use a balloon to stretch open the plaque, and thereafter we put a stent, or what we call metal scaffolding or ring, to prop it open so that the blood will flow through nicely. So this is an angiogram. In the top panel, you can see here where the arrow is, there's a tight blockage in the artery. Then in the lower panel here, this is another artery, where in the middle segment here, there is a tight narrowing as well in what we call the left anterior descending artery. So to treat this problem by stenting, first of all, we have this tight blockage in the middle of the artery. We can insert a metal stent to prop it open. So thereafter, the blood flow is restored and hopefully the symptoms of the patient has been taken care of. Well, certainly both stenting and bypass surgery can relieve the chest discomfort of the patient and can improve the quality of life. But it does not stop the underlying disease process, which is arteriosclerosis. The arteries can still get clogged up by fatty plaque and cause angina or worse, a future heart attack. Therefore, for all patients, do not stop your platelets for your blood pressure, diabetes, high cholesterol, or any medication you may take to support your kidney function, even when you think that they are under control, because these medications will be required to prevent future heart attacks. My final point will be, a lot of people think that if you have a kind of simple, straightforward heart disease, you just need some ballooning, stenting to treat it, whereas complex disease will require open heart bypass surgery. Both of these treatments are designed to treat coronary disease, but they are very different procedures. As you can see on the left, bypass is an open heart surgery where the heart has to be stopped and the surgeon has to expose the heart to restore the blood flow to the blocked artery. Whereas coronary stenting is a procedure done under local anesthetic with this small tube placed in your wrist. Increasingly, with technical advancement, these comparisons between the two modalities are very difficult. In general, it's true. Surgery will remain the standard of care for very complex coronary disease. However, angioplasty is now considered a good alternative in many cases. And in Singapore, especially at the Mount Elizabeth hospitals, we are increasingly tackling more complex multi-vessel disease in high-risk patients with angioplasty and stenting as an alternative to surgery. For example, this is a 39-year-old man who came with a heart attack, and actually he had blockages in all three of his blood vessels, but he declined surgery. So in the left anterior descending artery here, there was a blockage in the arrow on the left, so we put a stent there. And in the second artery circumflex behind with another 90% blockage below, again, we just put a stent across that. And finally, on the right side, there's also a long diffuse narrowing from the proximal to the distal segment. And this was treated with 2 stents. This is a relatively straightforward patient. All the blood vessels were unblocked. He returned to his normal activity. And this is not just a short-term fix. This was done almost 8 years ago. And till today, he's very well, exercising regularly, and he has gone back to complete normal physical activity with no problems. But some cases are more complicated. So this is a patient who came with a heart attack, and on the right side, where the red arrow, red line, dash line is seen, is where the blood vessel is supposed to be. But he had a complete blockage with lots of blood clots. So I used a balloon to stretch open the artery, but thereafter, you can still see that it's blocked because there's so much clot in the artery that could not be removed. So one option, of course, is to consider surgery. But in an unstable patient with heart attack, this is probably too high risk. So we actually have a very special device called what we call Angiogen. It's like a vacuum cleaner, a very high-powered vacuum cleaner that we place in the artery, and it flushes solution into the artery, and then we can suck out the blood clot. So thereafter, after doing a lot of cleaning, you can see now the blood clot is still present in the middle on the right side, but it's far less than before. And this allows us subsequently to implant two big and long stents to unblock the artery and restore the blood flow. As you can see in this final picture, the blood is flowing to the artery. What about cases where the arteries are very, very hard and stiff, where even balloon can't expand the artery? And typically, these are the patients that we will refer to surgeons. Again, in this patient, where there's a lot of hardened deposits in this long left anterior descending artery, the balloon couldn't stretch open the artery. So we actually use a special device, what we call a rotational arthrectomy or rotablator, with a diamond tip drill that can soften the plaque, crack open the calcium, and thereafter, as you can see on the right panel, we deployed the stent, and this patient did not have to go for surgery. A more recent development is another tool. So this patient here in the artery where the arrow indicates has a very hardened focal calcium deposit there, which block up the artery and has caused the patient a lot of chest discomfort. We use a balloon to stretch open the artery, but the balloon simply wouldn't expand because it's so hard. So we had a special new tool, a toy, what we call intravascular lithotripsy, IVL. And very similar to what is done to blast kidney stones, now we have a way to use sonic pressure waves to blast the calcium deposits. This device is called shockwave. It creates a localized field effect to soften the calcium so that we can use a balloon to stretch open the artery thereafter and then plant a stent to restore the blood flow to the heart. And for patients with complete blockages, 100% occlusion of the artery, as in this patient with 200% blockage, again, surgery would naturally be a first choice for him, but he adamantly declined surgery. So although it's technically difficult where we tried to pass a wire across the artery and couldn't cross the blockage, but we could use a special method to cross the artery from the other side of the heart. And finally, we managed to implant stents to restore the blood flow, and again, preventing a surgery in this case. And finally, for very high-risk patients with what we call left main disease, tight blockages right at the front of the heart, as well as 100% blockage in the middle. Again, although surgery would be a good choice, but again, this patient chose not to undergo surgery because he was only briefly in Singapore for a couple of days. He wanted to fly off within a week, and he had very strong views against surgery. So we were able to deploy stents in this high-risk patient in the front, what we call the left main, to the middle of the artery to restore the blood flow. Again, he was able to fly home after a few days. And again, this is not a short-term fix because this was done almost 8 to 10 years ago, and he's still well and still traveling. So in summary, in conclusion, I would like to advise everyone to understand your own health, know your risks, and take control of your own body and physical well-being. Look out for warning signs of symptoms of irregularities, and watch your diet and stay physically healthy. If you smoke, don't smoke. If you're a little bit overweight, try to control that. Go for a regular medical checkup, and please don't delay any treatment, or it may lead to significant complications especially when there are other concomitant illnesses when you present to hospitals. Thank you very much for your attention.
Our first question is from Mr. Ovidit Burwa. Is it too much of drinking water bad for normal kidney function? I mean, if someone drinks water in excess of normal recommended amount, when it will give extra workload for kidney?
I'll take that question. It depends what is too much. The average person living in a tropical country should be drinking anything between 2 to 3 liters of water daily. So if you snack a lot, for example, on potato chips, you may feel a lot thirstier than usual. Drinking up to 3.5 is fine. But anything more than 5 liters of water a day in a normal life, it's considered excess. And you may have to find out why you are so thirsty that you actually require to drink so much water. For example, excessive thirst and passing a lot of urine could be an early sign of uncontrolled diabetes. So it would be good to get that checked.
Thank you, doctor. Our next question is from anonymous attendee. I am 68 female. I had gallbladder surgery and removed long ago. Now I have abnormal creatinine levels, sometimes up and down. I am on medication to maintain this. Is there any signs for kidney failure in future? For note, I don't have diabetes.
With relation to the abnormal creatinine level, I think it is important to find out the cause of the kidney disease. We always treat the underlying cause of the kidney disease, be it high blood pressure, diabetes, or an underlying glomerulonephritis. The signs of kidney failure are very non-specific. Could be just lethargy, some leg swelling, feeling more tired than usual. Do look out for your own urine if it's more chalky or frothy. If so, getting regular urine tests and blood tests to monitor the kidney function would be very helpful.
Thank you. The next question is from Mr. Shahriar Zaman. How can I reduce potassium from food?
Okay, again, I think that's directed for the kidneys, because in kidney failure, potassium can accumulate. Foods that are rich in potassium include fruits like bananas, papayas, even the dried fruits like dried apricots, dried figs. These are all foods that are rich in potassium. So cutting down on these foods would greatly help.
Okay. Next question. Cholesterol builds up in the arteries. Calcium can also build in the arteries. Will it cause severe blockage? What is the advice or treatment for this?
All right, I'll take that question. Now, I think just to clarify, first of all, when we talk about calcium building up in the arteries, it does not necessarily mean that the calcium from our diet. So drinking milk or having a lot of calcium food doesn't mean you have a lot of calcium in your arteries. For our arteries, what happened is that for these blockages, initially you get a bit of inflammation in the arteries. Thereafter, your white blood cells will draw cholesterol or other kinds of material into the walls of the artery. Then you get this plaque that's full of cholesterol and white blood cells, inflammatory cells, and sometimes these blood cells break down and then they may form calcium. So which is why very often we look at calcium in the artery, because it's very visible on X-ray. Now, whatever happens in the walls in the heart, may it be cholesterol, scar tissue, white blood cells, or calcium, if they build up in the artery, it can cause severe blockage. So anything that is accumulated in this very small space in our coronary arteries can block up the artery. So how do we prevent that? First of all, it's still down to good risk factor control. Control your diabetes, blood pressure, cholesterol intake, regular exercise to minimize the buildup of these cholesterol and plaques. However, if the plaques are severe, when they finally cause a very critical blockage, then you will need a mechanical solution to either unblock it with using stents to widen the artery, or in some cases, is to consider a bypass surgery where the surgeons will put a graft beyond the blockage to restore the blood flow.
Thank you, doctor. Our next question is, if I have an episode of heart attack, What should I do besides regular dose of medication and change of lifestyle and diet?
Okay, maybe I'll take that question as well. Now, for the individual who had a heart attack, first of all, you want it to be well treated. In other words, a heart attack is due to a blocked artery. So you want to know where is the artery, has the artery been unblocked? Because some patients may not have treatment. So if you have a heart attack, know what happened to our artery in the heart. If there are blockages, unblock them, may it be through stenting or through bypass. So you want to establish blood flow. Once you do that, hopefully your risk will be lower. Then the key will be to preventing a further episode of heart attack. The most important thing is still down to medication. The two key medications to prevent heart attacks will be the antiplatelet medication, what we call the aspirin or clopidogrel or sometimes ticagrelor, as well as a statin, the lipid-lowering medication, not so much to lower the cholesterol, but they will stabilize the artery to prevent a heart attack. But at the same time, we must concentrate in addressing all the risk factors that may lead to further worsening of these plaques. There will be your blood pressure, diabetic control, managing your kidney disease, as well as a good and healthy lifestyle and diet.
Thank you, doctor. Next question. My kidney recovered from acute kidney failure. How cautious should I be with my diet? Will any deterioration affect my heart?
I'll take that question. So in terms of acute kidney failure, there are actually 3 different stages. Stage 3 being the most severe, where you may actually have required dialysis temporarily, and now you're off dialysis already. As we mentioned earlier, any episode of acute kidney injury where the serum creatinine rises more than 30% above baseline for a significant period of time, that can increase your future risk of chronic kidney disease, as well as the future risk of end-stage kidney disease, and also increase the risk of death. Therefore, a healthy diet, which means low salt, rich in whole grains, rich in fruits and vegetables, and not too much protein, 0.8 grams per kilogram body weight of protein, would help a lot in continuing to maintain good kidney health. And because chronic kidney disease is a risk factor for heart disease in the long run, maintaining good kidney health will also protect your heart.
Thank you, doctor. Our next question is from Marilyn Montanez. I have recurrent UTI, but was only given antibiotics every time. How should I prevent recurrent UTI? Do I need to always take regular urine tests to determine if I have UTI?
I'll take that question. UTI generally comes with certain symptoms, such as a pain or burning sensation on passing urine or having to go to the toilet very frequently, and each time there's only a little bit of urine. Sometimes you could even see blood in the urine when you go to the toilet, and this could be a sign of a urinary tract infection. If you have recurrent urinary tract infections, it is important to, first of all, get a proper urine culture to confirm that this is a recurrent urinary tract infection, meaning that it's caused by the same organism each time. For such patients, we can recommend long-term prophylactic antibiotics, as well as good perineal hygiene. Some people believe in taking cranberry juice or cranberry tablets, but again, that's 50-50. For some people it works, some people it doesn't work. To prevent recurrent UTI, good perineal hygiene, not holding your bladder, and that means every time you drink and you feel like passing urine, you should just go and pass urine and not wait for another 1-2 more hours, wait for the program or the movie to finish before you go to the toilet. That is actually a recipe for UTI, to keep holding your bladder. And do I always need to take a regular urine test? If it's your first episode of UTI, a lot of doctors will just treat as per symptoms. But if you have recurrent UTI, like I mentioned earlier, it is good to get the urine test done to find out if it's caused by the same organism that could turn resistant to the regularly used antibiotics.
Thank you, doctor. Next question is from Mr. Naim Hassan. What might cause high blood sugar after recovery from fatty liver grade 1? Hyperlipidemia and high uric and with a healthy diet and regular exercise?
Okay, maybe I'll take that. Now, I'm not sure about recovery. So I presume he meant that he has controlled his cholesterol levels and uric acid levels better with healthy diet and regular exercise. And maybe the fatty liver is not as prominent just in terms of liver function tests, but we don't quite recover in that sense from high cholesterol levels since it's not itself causing any symptoms. Now, however, correcting all those risk factors with diet doesn't affect your sugar in that sense. Firstly, we also need to clarify the high sugar, I presume, is high fasting glucose. So if it's a fasting sample of sugar that has gradually become higher, I don't think it's related to a high cholesterol or uric acid. It's just that the person may be at risk of developing diabetes, which may have happened along the way with age or with progression of disease.
Okay, our next question is from Mr. Montakim Arifin. I am cancer patients. Every 6 months, MRI and CT scans use contrast. So what can I do to my kidney?
Okay, I'll take that question. For a patient who actually has a normal kidney function, regardless of the cancer status, having intravenous contrast for MRIs, the gadolinium contrast is actually all right, as long as you have normal kidney function. Again, with normal kidney function, having regular CT scans with contrast is not a contraindication. However, it is important to ensure that you stay well hydrated so that whatever contrast is injected in is quickly excreted by the kidneys in the urine.
Okay, next question is from Mr. Mohammed Chaudhry. Is there any side effect to take long-term blood thinner like Ecosprin?
Okay, I presume you meant Ecosprin, that would be aspirin. Ecosprin is actually your local version of aspirin. Well, aspirin is important because it reduces the risk of heart attack and stroke by 30 to 50%. Now, but aspirin can also cause gastric side effects. So the most common side effect is that it causes gastritis, stomach ulcers, and it can be varying rate of 2 to 4% a year. And if there's any bleeding stomach ulcers, it can lead to perhaps even life-threatening bleed, but that would be less than 1% a year. So for patients with more sensitive stomach, again, you may want to combine aspirin with some gastric protective medication like omeprazole or Nexium, or alternatively, you may consider changing to, let's say, clopidogrel, which is a little bit gentler on the stomach.
Okay, next question is from Mr. Rafiqul Islam. I'm 41 years old. My cholesterol is high, no diabetes, no high pressure. How can I control my cholesterol?
Okay. Now, so for cholesterol issue, now again, 41 years old, you're in your 40s, so you're at a slightly higher risk. Now, cholesterol itself is not just a pass or fail kind of number. We do stratify the risk of individuals. Of course, not having diabetes, high blood pressure is good, but we also want to know, do you have any history of heart disease? Is there family history? Do you smoke? What is your baseline blood pressure? Because all these play a part to ascertain your risk of having heart disease. So if your risk is high, even if your cholesterol level is not so high, we will still want to treat with a statin. If your risk otherwise is low, then we can allow the cholesterol to be a bit higher. Like, for example, your LDL can be as high as 3.1 or 3.3. Nevertheless, to control cholesterol, the first step would still be very good dieting, reduce fatty food, oily food, saturated fat from your diet, exercise regularly, and lose weight. If we can't achieve a good and desired cholesterol levels, then statin would be a natural next option to reduce your cholesterol levels as well as to reduce the risk of heart disease.
Next question from Mr. A. Ghaffur. Can drinking of tea or warm water can be considered as drinking water?
Yes, it can. So as long as it's fluids, it can be considered water, as long as you also have some plain water in your diet. So I'm not talking about drinking 2 to 3 liters of tea, but 2 to 3 liters of warm or just room temperature plain water is considered as drinking water.
The next question from Mr. Shahadat Hossain. I have heart attack on 27th December. I'm under treatment. My echo test revealed the one of valve grow MR. So what should I do? And my heart effect is 36%. How can it be increased?
Okay, taking this question, first of all, the heart EF is what we call ejection fraction and how well the heart pumps. For a normal individual, your ejection fraction should be about 50 to 75%, average about 60. So if your ejection fraction is 36%, that means it's significantly reduced in what we call moderately impaired ejection fraction. And also one of valve shows MR or mitral regurgitation. Now again, mitral regurgitation has varying grades. It can be mild, moderate, or severe. If it's more, certainly some form of intervention or surgery may be necessary. Now, how do we improve the EF? First of all, if you had a heart attack, the best way to improve the ejection fraction would be to consider any form of revascularization. If you have existing blocked arteries that are still not cleared, then you want to unblock them or restore them or undergo bypass surgery to restore the blood flow. That is the best chance of improving the ejection fraction. If that is already done and the heart function is still poor, then again, sometimes the ejection fraction may not improve, but medication can help to stabilize the heart, to reduce the symptoms, and to prevent any progression of worsening heart failure.
Thank you, doctor. Next question is from Mr. Rahman. I am 50 years. How we can maintain the serum creatinine level as standard level?
So I assume that at 50 years old, if you have normal kidney function, I mean, using the SI units, standard international units of micromole per liter, the serum creatinine should be double digits. That means less than 100. If you're a normal healthy individual, I think maintaining good health, a good healthy diet, healthy lifestyle, as mentioned in my talk, is very important. If you have other risk factors like diabetes and high blood pressure, again, we will control all that to keep your serum creatinine in the normal level.
Next question is from Mr. Montakim Arifin. I am cancer patient. Every 6 months, I do MRI and CT scans, use contrast. So what can I do my kidney?
Farzana, I think I addressed that question earlier already.
Okay. Next question is from Mr. Paulo Christian Barista. What tests do you recommend for patients to be able to identify who may be having an X or CAD, particularly to those who are asymptomatic?
Okay. Now, so basically you want to identify whether a patient has coronary artery disease. So the short answer is, especially for otherwise asymptomatic patient, you can consider doing a CT scan, CT coronary angiogram, mainly because you want to visualize the arteries to see whether there's any coronary disease. Of course, the gold standard test will still be a coronary angiogram, the one that's invasive and you go to the hospital to get. But this is obviously not necessary for most individuals. So again, CT scan is probably a good initial investigation. But of course, we do have to know that the test does incur some costs. It does have some radiation, and it does involve contrast. So you have to make sure that the kidneys are reasonably healthy before you do that. Again, we will do this for anyone that we are suspicious of having underlying disease, but perhaps not for a young, otherwise fit person. Let's say a 30-year-old lady with no other risk factors, we certainly wouldn't do that. But let's say it's a 45-year-old smoker who has no symptoms, but strong family history, some vague symptoms, then a CT scan as a first investigation will be quite appropriate.
Thank you. Next question. Is arrhythmia common for elderly people? Is it life-threatening then?
Okay. Now, arrhythmia is a very general description of an abnormal heart rhythm. So it can be something totally benign to something that is far more dangerous and can even cause fainting spells. So arrhythmia itself, of course, is very common for almost everyone, but with age, it's even more significant. Certain kinds of arrhythmias, such as heart blocks, ventricular fibrillation, atrial fibrillation, can be more serious and potentially lead to life-threatening events. So if there's any suspicion, I would suggest that these patients to get a check, do an electrocardiogram, look at the underlying rhythm so we can know what type of arrhythmia they have. Is it a benign form or something that needs intervention and treatment?
The next question is from Mr. Obaidur Rahman. Is taking baking soda and apple cider will help to clean kidney for CKD patients with 20 to 22 eGFR?
Baking soda is an alkali, and for someone with that's about stage 4 chronic kidney disease, the acid level could be quite high, and in which case taking sodium bicarbonate, which is what I usually use, rather than baking soda, would help to neutralize some of the acid level. Now, apple cider is, I assume you're talking about apple cider vinegar. It is just apple juice, fermented apple juice. And when we talk about juice, right, so if you imagine eating one apple versus a glass of apple juice, the glass of apple juice probably requires more apples, maybe 2 or 3 apples to make a glass of juice or a glass of cider. And sometimes that increases the sugar content compared to the food itself, and it may increase the potassium content as well. So in terms of cleaning the kidneys when you have apple cider, I am not aware of any studies that have been published to date to suggest that apple cider will help to clean the kidneys. Neither does baking soda clean the kidneys, but it could neutralize the acid for someone with advanced kidney disease.
Okay, we have got the last question from Mr. Mizanur Rahman. Without conditions mentioned in both of your talk, what are the regular checkups that both of you recommend for healthy heart and kidneys for someone like me who is in the 40s? Do you consider?
Right, okay. Maybe I'll just mention, so for regular, if you're otherwise healthy with no specific concerns, I think it's still very important for us to establish, make sure you check your blood pressure, check your cholesterol level, make sure you don't have undetected diabetes. So going for a regular blood test, maybe every 1 or 2 years may be good. Do check your blood pressure at least every 6 months to 1 year, so that it wouldn't you wouldn't get a silent high blood pressure that will lead to other problems. Other things that you may want to consider as a health check as you approach your 40s or 50s, so make sure your stool is okay, make sure there's no blood in your stools or undetected polyps in your colon. So these are the usual recommended health screening things that we'll suggest. Perhaps Angeline will add on for any specific kidney problems.
I think for the kidneys, you just have to look out for frothy urine or chalky urine. And if you have any of those, do see your doctor for a urine test to look for blood or protein in the urine, because these are all subtle signs. Otherwise, in terms of general health screen, I agree with what Stanley has just said.
Thank you so much, Dr. Chia and Dr. Angeline. I think we have answered most of the questions. If you have more questions, you can ask us to the regional offices. I would like to thank Dr. Angeline Goh and Dr. Stanley Chia for delivering such wonderful presentation today. I hope this little initiative from Mount Elizabeth Hospital has benefited you. Meanwhile, if you have more queries, do not hesitate to contact our regional office in Dhaka, Sylhet, Chittagong, in Bangladesh, and in Manila, in the Philippines. To remind further, our regional office services include professional recommendation for treatment option and doctors, provide advice on the estimated cost of treatments and procedures, evaluation and repatriation assistance, medical arrangements to secure an appointment within 24 hours, flight and accommodation arrangements, visa application and extensions, airport transfer arrangements, multi-language translation, interpreter service, special food and beverage, religious arrangements, post-care support, other services upon request. Thank you once again, everyone. Thank you for joining us today, and we will see you next time. Till then, follow the health guideline and stay safe.